Hello, Dr. Gomez from UT Health San Antonio, and today we're going to continue with the MSK cases, rapid fire style cases number 26 to 50. Here we have PA, views of the hand and the pelvis, and we see that there are multiple lucent bubbly lesions within the phalanges and metacarpal bones of the hand, as well as multiple bones of the pelvis and left proximal femur. These lesions are expansile, have endosteoscalloping, and may have some punctate matrix inside. These are multiple enchondromas within the body, and this is a diagnosis of enchondromatosis, also known as Ollier's disease. When you see multiple enchondromas and osteochondromas, it's called metachondromatosis. Also important to remember that enchondromatosis or Ollier's has an increased risk of degeneration to chondrosarcoma, somewhere from 25% to 40% increased risk. Here we have patient with multiple views of the right hand, and we see that there are multiple expansile osseous lesions throughout the phalanges and metacarpal bones. Similar to the prior case, these lesions have endosteoscalloping and expansion, and some of them have punctate matrix inside the lesion. Again, this is a person with multiple enchondromas throughout the body, a type of enchondromatosis, but we also see all these soft tissue lesions giving this bumpy appearance, and with multiple phleboletes all around the hand and wrist. So these are multiple soft tissue hemangiomas. So the combination of multiple enchondromas and soft tissue hemangiomas gives us the diagnosis of Maffucci's. And these patients also have an increased risk of degeneration into chondrosarcoma. And this patient had already multiple amputations of the fifth finger, as well as the distal ulna because of degeneration to chondrosarcoma. In this case, we have two views of the hands in PA, and we see that there is ulnar deviations at the metacarpal bones bilaterally. However, we see that there are no erosions, no marginal, central, paracentral erosions, or any destructive changes of the bone. So this is a case of lupus or deforming non-erosive arthropathy, and it's historically known as Jacoud, which is associated to rheumatic fever, but now it's most commonly seen with lupus. So whenever you see ulnar deviation and a deforming arthropathy of the hand without erosion or bone destruction, think about Jacoud, which is today mostly seen with lupus. Case 29, we have a PA view of the hand and the forearm, and we see that there are clumps soft tissue calcifications, not ossification, is cloud-like, chalk-like around the interphalangeal joint of the thumb. We see some here superimposed in the bone within the soft tissues. And we also see here in the forearm, they're sheet-like and there are calcifications. This is another patient with the same condition. We again see some soft tissue calcifications, but we also see some acrosteolysis and soft tissue resorption. This is a patient with scleroderma, and this is fibrosis of the soft tissues. That's why you see so much resorption, almost like there is no soft tissue, and the acrosteolysis. And they have multiple calcifications just because of tissue necrosis are related to the fibrosis. So acrosteolysis, soft tissue calcification, soft tissue resorption, consistent with scleroderma in the MSK system. In case 30, we have AP and lateral views of the wrist, and we see that the lunate is not really articulating well with the scaphoid, the capitate, or the triquetrum. And in the lateral view, we can clearly see that the lunate is completely dislocated volarly with respect to the radius. So here we see the lunate, and it's not articulating at all with the distal radius, and it's not articulating with the capitate either. So this is a teacup appearance of the lunate, and we see this in lunate dislocation. The important thing is differentiating lunate dislocation from perilunate dislocation and fracture. And in perilunate fracture dislocation, the lunate actually articulates with the radius, but then the capitate will be dislocated from the lunate. But when you see full dislocation of the lunate from the capitate and the lunate, remember it's lunate dislocation and not perilunate. Case number 31, we have AP and lateral views of the right leg, and we see that there is some rounded calcification with a lucent center in the soft tissues of the mid-posterior leg, and this is consistent with phleboletes. So we're thinking that there is some type of vascular malformation within the soft tissues. In this patient, we did an ultrasound and we see this well-defined echogenic mass, and there is some internal vascularity within the lesion, and we can see a calcification. So we're certain that this is a soft tissue malformation, likely a hemangioma with the presence of a phlebolith. So in the MRI, we have T1 and T2 weighted images, and the important things to remember about hemangioma in the MRI is that there is intralesional increased T1 signal intensity because of presence of intralesional fat. Also, you can see a feeding vessel sometimes, and you can see the tubular structures of the vessels within the malformation. When we give contrast in the MRI, the lesions will enhance, and you can better see the feeding vessels. So remember, you can see a phleboliths in the soft tissues. You can see it on ultrasound. It may have some slow flow on ultrasound, increased T1 signal intensity within the lesion related to fat, and you may see a feeding vessel and the tubular enhancing structures. And this is all consistent with a soft tissue hemangioma. Case 32, we have ultrasound and MRI images of the distal leg or ankle in a pediatric patient. And in the ultrasound, we see that there is a complex fluid collection adjacent to the cortical bone, right? There's the cortical bone, all the sound is absorbed, but we see this fluid collection, which is hypoechoic with some debris inside. In the MRI, we see that there is a high T2 signal intensity or fluid collection between the periosteum and the cortical bone, and this is consistent with a subperiosteal abscess, which you could actually see in ultrasound. And it happens in the pediatric population because the periosteum is not really that strongly adhered to the cortex. And when you have hematogenous osteomyelitis, usually in the metaphysis, it will try to get out of the bone and it will go out and accumulate between the periosteum and the cortex. So subperiosteal abscess. Case number 33, we have axial T2 and T1 images of the proximal thigh and then coronal T1 post-gadolinium, and we see patchy increased T2 signal intensity within the anterior and posterior muscle groups of the proximal thigh. This is related to diffuse myositis. And when we contrast, it enhances, so it's an acute and active myositis because it's diffuse, and in the proximal musculature of the thigh, we can favor the diagnosis of dermatomyositis. T1 weighted images, the muscle looks okay, so this is a fairly acute process. But do remember that when we have chronic myositis, what happens is that this edema will turn into atrophy, and this is seen in muscle with fat accumulation within the muscle fibers, like you will see in a chronic rotator cuff tear. So acute diffuse myositis, systemic process, we favor dermatomyositis. So we have PA oblique views and cone down views of the area of interest in the right foot, and we see that there is intermetatarsal soft tissue, kind of linear calcification. It is not really a phlebolith because it doesn't have a lucent center. So we should have a soft tissue calcification in this patient that came with a palpable mass. So we order further evaluation with MRI. So in the MRI, we find that there is a bilobulated mass at the first and second intermetatarsal region that shows mostly intermediate T1 signal intensity, mostly high T2 signal intensity with central regions of necrosis and diffuse heterogeneous enhancement. In the MSK system, any enhancing soft tissue mass is suspicious for a sarcoma. And in this case, because of the location being in the foot and also because of the calcification, we favor a synovial sarcoma, which was the diagnosis in this patient. So any enhancing mass within the soft tissues of the hand or foot or around the ankle that has calcification and no intralesional fat, you should think about a synovial sarcoma. Ultimately, the diagnosis has to be confirmed with a biopsy. Case 35, we have axial and T1 and T2 fat sat images of the hand as well as coronal T1, and we see that there is fatty enlargement of the median nerve, which is within the carpal tunnel. This is the carpal retinaculum and the flexor tendons, and we see these nerve fibers look like cords within the median nerve that have been kind of displaced and surrounded by fat. We know it's fat because it's high on T1 and it diffusely suppressed on the fat T2 fat sat images. So this cord appears in the axial, and this spaghetti appearance on the coronal images is very characteristic of a Fibrolipomatous Hamartoma, which is a benign neoplasm of the nerve that gets proliferated with fat and fibrous tissue. And this comes in the test because the imaging findings are very, very characteristic of the diagnosis, and also because it's associated to macrodystrophial lipomatosis and macrodactyly. Case 36, we have AP and lateral views of the left knee in a patient with prior ACL reconstruction. And we see that there is degeneration of the knee joint with osteophytes, but there is also distension of the joint at the suprapatellar space, infrapatellar space, and also at the posterior aspect of the knee joint. And there are multiple intra-articular ossific bodies, not calcification, but ossifications. And this is a patient with secondary synovial osteochondromatosis related to the degeneration and osteoarthritis. It can also be primary. So there is a hyperplasia of the synovium, and this hypertrophy synovium gets dislodged and forms loose bodies throughout the joint. When they're not calcified, we call it synovial chondromatosis, and it's in the differential diagnosis of PVNS, just because PVNS doesn't calcify. But once it calcifies, we can say synovial osteochondromatosis. And remember, it comes in the primary one, which is idiopathic, and the secondary one, which is associated to degeneration. Case number 37, we have AP and lateral views of the ankle in a patient that had fixation of the hindfoot due to trauma, not really with the purpose of arthrodesis. And we see there are multiple regions of perihardware lucency, more than 2 millimeters, here in the inferior aspect of the tibia and the AP view. And we can also see here in the metaphysis of the tibia and the lateral view. We see lucency surrounding the fixating calcaneal screw, as well as retraction and lucency of the proximal fixating screw. This is a patient with hardware infection. You can have aseptic loosening, and you can have infection when you have perihardware lucency. The only thing that can help you is that when the perihardware lucency is symmetric about the entire hardware, it's most consistent with aseptic loosening. But when it's asymmetric, like this one, some regions are much larger than others, it's usually infection, because infection usually does not affect the whole hardware completely. It's just several portions of it. And of course, when you have infection, you have loosening. You also can see a lot of periosteal reaction here around the fibula and distal tibia, which are also consistent with infection. So asymmetric perihardware lucency, more than 2 millimeters, think infection. Symmetric, think loosening. Case number 38, we have PA views of bilateral hands, and we have multiple findings in these hands, but we see a lot of destruction about some of the interphalangeal joints, and we also see some paracentral erosions here at the proximal interphalangeal joints. This is a patient with psoriasis, and psoriasis can have several findings, but one of them is pencil in a cup deformity because of the extreme destruction at the interphalangeal joints. Also, we can have this Mickey Mouse ears, and the Mickey Mouse ears is pretty much paracentral erosions that give you that appearance that look like the ears of Mickey Mouse. Also, we can have a sausage digit, but pencil in a cup, Mickey Mouse ear are very consistent with psoriasis, which is one of the negative spondyloarthropathies. So here we have a hand with another enchondroma. This one is single and not multiple, like Olier's and Maffucci that we mentioned before. So we're going to dig deep into enchondroma. So enchondromas are common in the hand. There are chondroid lesions. They are benign. They are lucent. They can have endosteal scalloping, and they make the bone weaker in the phalanges and metacarpal bones, so it can be associated to fractures. So let's see. They can degenerate into chondrosarcoma, and the things that we're looking for is endosteal scalloping more than 2/3 of the cortex, cortical breakthrough, periosteal reaction and soft tissue component, or new onset of pain that is not associated to a fracture. All those things may suggest that there is degeneration to chondrosarcoma. We see them incidentally in knee MRIs, and less than 1 centimeter, we shouldn't do anything about it. More than 5 centimeter is probably degenerated just by size alone. In anywhere from 2 to 5, 2 to 5 centimeters is a matter of should I follow it up or should I biopsy. So it's kind of a controversial issue, but those are the things you need to know about enchondroma and degeneration to chondrosarcoma. Case number 40, a patient that came with knee pain and got radiographs, and it looked pretty negative. When we did a PET CT scan, we see some sclerosis here at the distal femur metaphysis and epiphysis that is avid on PET. And we can see that there is really no disruption of the trabecula. So we're thinking about a very active lesion that does not destroy the trabecula. In the MRI, we see that this lesion is low on T1 and high on T2 signal intensity, but again, it doesn't have any perilesional edema and it doesn't have any trabecular destruction. This is a case of primary lymphoma of the bone. You see one, you've seen them all. So it's usually an invisible lesion because it doesn't destroy the trabecula on radiographs. You can barely see it on CT, it's avid on PET, and it's very obvious on MRI, but does not destroy the trabecula. Just think about lymphoma, for example, of the kidney and pancreas that would enlarge the organs without actually causing any disruption to the form of the organs itself. And in the bone, they grow around the trabecula without destroying them. So here we have AP and lateral views of the chest, and we see that there is no clavicle on the right side and there is a hypoplastic clavicle on the left side. Whenever you see that there are no clavicles in a chest radiograph, you have to think about Cleidocranial Dysostosis or dysplasia. And this is a autosomal dominant genetic disease that is pretty rare, and it's a problem in the membranous bone ossification. And it can have a lot of findings such as large fontanelles, Wormian bones, supranumerary teeth. But what you need to remember the most is that they don't form, they have a genesis or absent or small hypoplastic clavicle, and that should give you the diagnosis of cleidocranial dysostosis. Case number 42, we have AP views of bilateral knees, and we see diffuse soft tissue dystrophic calcifications. Dystrophic because they are sequelae from soft tissue necrosis, and those are 95% of the soft tissue calcifications. This is a case of dermatomyositis. We saw previously the acute finding with muscle edema and enhancement, but later on when you have muscle and tissue necrosis, it ends up calcifying. And diffuse soft tissue calcification, dermatomyositis, is in the differential diagnosis. Case number 43, we have ultrasound images, transverse and longitudinal of the posterior proximal leg, and we see that there is a lentiform shaped fluid or hypoechoic collection between the soleus and the gastrocnemius. This is the gastrocnemius and the soleus deep to it. So this is an intermuscular hematoma, and we're thinking of a gastrocnemius there. In the MRI T1 and T2 signal intensity, we see this fluid collection, which is actually blood because it shows high T1 signal intensity with methemoglobin. And we can see that it's actually within the gastrocnemius muscle, and some of the blood is extending between the soleus and the medial head of the gastrocnemius, but most of it is within the muscle here. And there is some edema around the muscle, so this is a medial gastrocnemius tear, which is the most common thing we see when we hear a pop and a patient in the leg. We used to think that this was related to a plantaris tear because of the blood between the muscles, but we now know that the overwhelming majority is related to a medial gastrocnemius tear. Case number 44, we have coronal images of the knee, both in the T2 fat suppressed and T1 sequences, and we see that there is a lot of edema at the medial femoral condyle that shows low T1 signal intensity, and we see some subchondral low signal intensity on the T1 and the T2. So this is an insufficiency fracture of the medial femoral condyle that was used to be known as SONK, spontaneous osteonecrosis of the knee. But now we know that it's not a vascular process, but a traumatic insufficiency fracture. So we should call an insufficiency fracture of the medial femoral condyle and not SONK. But this is what we see, this subchondral fracture here, right in the weight-bearing medial femoral condyle with extensive edema around the condyle extending to the metaphysis. Case 45, we have a lateral view of the ankle, and we see that there is osseous continuation of the talus and the calcaneus, and we also see a talar beak. This is a classic case of Tarsal Coalition between the talus and the calcaneus, and it creates this talar beak just because of the abnormal mechanics created to the pure mobility at the subtalar joint. We can also see calcaneonavicular coalition, which is actually slightly more common than the telocalcaneal. And those are the two coalitions we see at the tarsal bone. So remember about the two classic signs will be the C sign because of the osseous bridging at the posterior subtalar joint, and the talar beak, which is created because of the abnormal movement. Case number 46, we have views of the chest and cone-down views of the right upper chest. And we see that there is a lesion within the posterior aspect of the first rib. We can see it here. And this lesion shows expansion and ground glass opacity. This is a fibrous dysplasia. And the ground glass opacity is pathognomonic pretty much of the lesion of fibrous dysplasia and is very common in the ribs as it is in the bones of the pelvis, especially the proximal femur. So things you need to remember about fibrous dysplasia: it can be monostotic or polyostotic in multiple bones. Polyostotic, you have to think of several syndromes like McCune-Albright with café au lait spots and precocious puberty. Also, it can cause deformity when it's in the femur, like a Shepherd-Crookes deformity. So ground glass opacity, ribs, proximal femur, Shepherd-Crookes deformity, McCune-Albright, all those things you need to remember when you see this lesion. So case 47, we have AP view of the pelvis, and we see that there is thickened trabecula on the right proximal femur as compared to the left side. This is a case of Paget's disease. Paget's has three stages, but what you most commonly going to see is that thickened trabecula either in the pelvic bones or in the vertebra. Remember, when it's acute, you can see that blade of grass appearance, which is when the lytic phase is advancing through the bone, also called as flame shape. Buzzwords for Paget's disease in the skull is cotton wool skull or osteoporosis circumscrita. In the vertebral bodies is picture frame vertebra because of thickened trabecula peripherally and enlargement of the vertebral body. And again, the flame shape or blade of grass. And the most characteristics is just the thickened trabecula. Remember that pagetoid bone can degenerate into osteosarcoma. It's important to remember. So case 48 is a companion case to 47 of Paget's disease, and this is just to show a picture frame vertebra of Paget's because of peripheral trabecular thickening, and notice how this vertebral body is actually larger than the vertebral bodies adjacent to it. So picture frame vertebra of Paget's disease. Case 49, we have bilateral views of the legs, and we see that there is a disturbance and destruction and irregularity at the medial proximal tibial growth plates, and it's bilateral. And this is consistent with Blount's disease, which is osteochondritis of this local part of the proximal tibial growth plate. So it's a growth disturbance, and it's in the eponyms of the osteochondritis. So you see one, you see them all. Remember, Blount's, also known as congenital tibia vara. Case number 50, we have axial images through the shoulder in a football player, and we see that there is edema here and throughout the muscle that attaches to the acromion, but that goes medial. And this is a case of pectoralis minor tear, and this is one of the cases that I put just to remind you that you kind of need to know your anatomy. There is edema and irregularity of a muscle, and if you know that the pectoralis minor inserts at the acromion, you know that there's a pectoralis minor tear. But also it helps that there's a young football player that had a pop or heard a pop and pain when he was pushing another player. So pectoralis minor tear.